So you have a procedure to open up those blocked arteries or the narrow vessels in your legs for a disease known as peripheral artery disease. And then what happens? You're discharged, right? Mm, well, maybe not in the future, because we have a couple of researchers that are here that are going to be talking about some results to a study that many of the folks in our network with the Global P.A.D. Association actually participated in. And the research was around post-procedure protocols. Should a patient walk? Should they be in a walking program? Should they have a gradual program to get them up to speed? Who knows? We're going to find out from Dr. Stefan Birkett. We had this debate right before, right? Should we say Stefan Birkett? He's an exercise physiologist out of Manchester, and we also have Joanne Duff, and she is also a researcher. She's working on her PhD in Manchester. Thank you both for joining us. And we're excited to hear. Why don't you start with a little bit more about each one of you and your interest in PAD and interest in the post-procedure protocols, and then we'll get more into the study.
Yeah, I've got some slides to share as well when you're ready,
Oh,
Kim. So that's
perfect.
great.
Yeah.
So welcome everybody, and thanks for inviting us. Really important to meet everybody and get involved in really great groups like this to support people with the PAD. So my background is from an NHS perspective as a clinical exercise physiologist, where I worked in cardiovascular rehab. So we provided rehab for heart attacks, peripheral artery disease, bypass surgery, heart transplants, you name it. We rehabbed it in terms of cardiovascular. And then I did, while I was working in the hospital, I did a part-time master's in cardiovascular rehab. And then a professor approached me if I wanted to do a funded studentship looking at high intensity interval training in cardiac patients, where we push patients to quite vigorous exercise. And so went and did that, and then got into academia, and then, the bug of research and trying to improve patients' outcomes and quality of life really took hold, and here I am.
I love it. What about you, Joanne? You're working on your PhD. And
I am,
somehow
yeah.
you got roped into PAD.
I know, I don't know. Yeah, so I'm cardiac physiologist by background. Worked at the NHS for a long time, and then worked for a charity where we do cardiac rehabilitation. We also then do stroke rehab, pulmonary rehab, and we set up the P.A.D rehab classes. And so that's how I got to know Stefan, and it was setting up the P.A.D classes, and I just noticed such a massive difference from when they first start, and just by doing that walking and having that support and that education and that sort of little arm around the shoulder to encourage them, and the differences they could make was unbelievable. And I just was fascinated by this. And so then I sort of said to Stefan, could I pay just to do a PhD through Manchester Uni in this, because it's fascinating. So yeah, so I'm sort of in my 4th year now, so this has been my project that I've been doing from a PhD. Stefan's my supervisor. Just loving it, man. It's just a whole new world to me, but absolutely fantastic. I'm really enjoying it so far. I really want to make a difference for people who have peripheral artery disease.
I mean, that's music to the ears of so many, especially in the NHS, that the passion that you have for it, because for so long, and even up till now, there still are so many that ignore it, that brush them off, that discharge them with no guidance. And it really is comforting to hear that there are people that care and that are really working on advancing care for people with PAD. We just had a patient that was on here a few moments ago, and he dropped off, but Paul was on here, and he was talking about his doctor just wanting to throw him into a major bypass surgery. And he said, well, I don't understand. I thought from your group, we've learned that you could build collateral vessels. I know I have a wound on my toe, but it's healing. He said very slowly, but why do I need this bypass? Why can't I just go through a really rigorous exercise program and build the collateral vessels? And I mean, that's what we're excited about with what you guys and what Dr. Christinen out of Scotland and his team, and even Kathy here as a patient, but also participant in multiple trials and on the research team out of Scotland for exercise physiology for PAD. I mean, walking is the best medicine. It's the most durable, but they're not offering it as a regular program for people as medicine, right? A prescription with structured exercise and putting money into these programs. And that's really frustrating.
Yeah, we know we did a earlier bit of research that was published with our group that looked into the provision of supervised exercise programs in the UK, and less than half of the vascular team had access to supervised exercise. So 48% of all vascular surgeons, consultants, vascular clinics, only 48% had access to refer a patient to supervised exercise. So unfortunately, especially in the UK, it's still a postcode lottery of care where, if you live in Manchester and Preston, you get access to lovely 12 weeks of supervised exercise with education. If you live a bit more north towards Scotland, just sort of in South Cumbria, there's nothing. And that's the problem that we have, that there's the evidence is so strong, so robust for the benefits, yet it's not commissioned. And I think that's a funding problem and staff and facilities more than anything.
And that's why I know that you guys are working in the UK on some remote programs. The only thing is then distributing the devices and still the cost of these devices versus just literally saying, here's an app. We don't need to get your blood pressure. We don't need to get your pulse. Just walk to a certain limit, and at least it's something, right? If they could just have a basic program, roll that out first, and then have additional iterations that might include, the blood pressure cuffs or, pulse readings and such in the future.
Agreed.
So that's right? That's preventative. We don't want a procedure. We're going to try to grow collateral vessels, but then we have post procedure. So the patients that end up with severe lifestyle limiting claudication or CLI, critical limb ischemia, the most advanced stage, with wounds that maybe won't heal, or rest pain that wakes them up at night, and they need to have a bypass, or they need to have some sort of endovascular procedure to rotor-root their arteries. And then after that's done, they're discharged. But your research is showing that there would be some added benefit if we had better post-procedure protocols that include better monitoring, that possibly included a structured walking program, correct?
Yeah, we're in the early stages of doing this research, and the first stage, which I can present, it was co-designing, so reaching out to patients and what would they like their rehab to include, instead of it being top down, where a clinician saying we're going to do this, we're going to do that. Well, we actually wanted to include patients of what they wanted to do in their rehab. How would they like it delivered? Where, when, how often? Also, education, came up as very important. So the patients told us what topics they would like covered in their education package, and so we got all that together. And then the next phase will be to test it to see if it's feasible, whether patients actually take part, complete the program, and then get some outcomes in walking performance, quality of life, and measures like that.
And so, Joanne, do you have anything to add to that before he brings up some slides to show us what he's got?
No, I think the most important thing for me, again, sort of coming from a cardiac rehab, it's been so well researched, but it would have been very easy for us just to say, right, this is the rehab program, this is what we're going to do, let's test it. the best thing that, from my point of view, has been integrating the patients and the people with that lived experience into this, and then being part of this procedure. And I think that is so important, and I'm really glad we've been able to do that. So that's been a real sort of nice side that I've taken from this as well, that, you know, you guys have all been a part of this, which is great.
Yeah, so we're excited to see. So go ahead and share your screen. I heard we had quite a few people from our network that participated in this. So
Yeah.
can
we all see that?
let's see. Yes, we can.
Perfect. Okay, so I'll just make a start. So the program's abbreviation is called HOPE, and really behind that was hope that we can make things better for CLTI patients after, because unfortunately they go through it, and currently there's nothing for them out there at the moment in the UK. So we thought, well, we can give it an acronym, HOPE, and move it forward. This is NIHR funded, which is great. They've invested a lot of money into these first development stages, and we hope to take it forward, okay, and deliver meaningful impact. So without, boring people too much, you might know these figures already, but we know that 236 million people are affected by peripheral artery disease globally. That's going to increase by potentially 50% by 2045. So it's not going away. Okay, we live in an aging world at the moment. So, and peripheral artery disease is more common in older people, and so therefore the prevalence and incidence is going to increase. So people are not going away with P.A.D. It's something that we need to deal with. And so the most severe form of P.A.D. is kind of more end stage, and that's chronic limb-threatening ischemia. And around about 11% of people with peripheral artery disease go on to develop CLTI. So as Kim mentioned, you've got your symptomatic claudication, and as the disease process continues to build, the atheroma, or the buildup of fatty plaque in the lower limbs, it then cuts off blood flow completely to the extremities. And that's why people who have had CLTI on this call, or know people, they get resting leg pain. If then they get no blood flow to the lower limbs, they can get gangrene, ulcerations, things like that, and that's tripled with diabetes. Okay, so the two kind of go hand in hand, and the outcomes are not great. So I don't know if any of you seen these figures, and this is what really hits home to me, and really, I had this idea probably 4 to 5 years ago, and so it was, it was coming through. So despite successful, and that's really important, despite successful revascularization, so that's stenting or bypass, patients still remain at significant risk. So this is data from 1 and 3 years. So at 1 or 3 years, there'll be up to 20% of patients will have an amputation at the toe, below the knee. At 1 and 3 years, 42% will have still suffered a major cardiovascular event like a stroke or a heart attack. And 50% will have died, okay, towards 5 years. So the outcomes are really, really serious. So like Kim said, is they have peripheral artery disease, they're told they need surgery, they have successful surgery, and then in essence, brutally, they're kicked out the door to fend for themselves.
Yeah.
And the percentages there are really, really horrifying in terms of, yes, in 5 years, 50% will have died. Okay. And I've experienced that in its truest sense, because when we put the NIHR grant together, we had a patient co-applicant, and he died during the grant application. So really hard-hitting numbers that we need to address. We can't just turn a blind eye to this anymore, and we need to. Can we do something to try and reduce that amputation, cardiovascular event, and reduce mortality? in conjunction with improving people's quality of life. Now, claudication research is slightly different to CLTI research, as in these two papers here have actually shown that those with claudication who need surgery, exercise is an optimal strategy. It improves walking performance, both walking performance, and it improves cost effectiveness to the healthcare system. So for claudication, it seems to work. However, if you go and have a look on any clinical trials website, look at in any of the literature, which is what we did, there is no clinical trials looking at rehab or exercise in CLTI after surgery. None at all. None at all. So that really sort of pricked our ears up and said, right, okay, the evidence is really strong about poor outcomes. Let's go and have a look to see what evidence there is. And alarmingly, I came across 0. So it was like, right, okay, there's a research gap in here, and there's a whole bunch of patients that would benefit from having something. So that is what really stemmed this grant and now this research.
This is I'm talking literally across the globe.
Nothing.
No. I mean, this is history in the making right here. No joke.
No, and the guidelines are very wishy-washy, because you've got some significant bodies, European Society of Cardiology, European Vascular Society, all these bodies here, and they're all saying, research exercise would be good or could be good, and they have to use that terminology because there's nothing, they can't hang the hat on it and say yes, it's definitely good. It's category evidence. So this is where we are. So what we did was we used a research method called a modified Delphi, and the robustness or the strength of this design is that it brings healthcare professionals, patients and carers all together to try and build a rehabilitation program. Okay, so gone are the days where it's just the researcher dictates what the rehab's going to be based on their own opinion. It's let's ask the people who it's built for and what do they think. And the method is 3 rounds. So the first round, and so I recognize some of the faces on this call. So the first round was open-ended questions, and that was focused around rehabilitation, exercise, and education. Joe then analysed everything for the trial, which is amazing. Based on those responses, then round 2 was a little bit more tailored questions, and where we wanted to try and establish a bit more of a framework of what the rehabilitation program would look like. And with this methodology, we tried to get consensus, which 70% of the people who took part agreed with a certain item, and that's what we defined as consensus. We then had round 3 was an online workshop where we invited everyone to take part. We discussed all the elements that was a strong yes to be included, and those that were a bit 50-50 or not quite consensus, we took to a vote and in breakout rooms to discuss and things like that. So by the end of round 3, we were able to have a definitive framework of a rehabilitation program that include exercise, relaxation, and education. So round 1, just to sort of give you an overview of what we did, we had 37 patients and carers actually took part in round 1, and many of them from this group, which is amazing. We got 35 items from these questionnaires were generated. They were put into round 2. Now, naturally, with any research, we get a little dropout rates, and that's absolutely fine. That's just part and parcel of it. So we had 16 patients and carers take part in this one. 23 items of the rehab were achieved consensus, 12 did not. And then we had a round 3, which is the focus groups, and we got all items, achieve full consensus, and we were able to sort of define our rehab program. Now, some of the comments that we got from patients in the questionnaires are really, really important. Joe's picked these two out picked these three out as sort of some of them are hard hitting. So rehab is an essential pathway to the best possible outcome. Exercise is needed as much as food and water, and education empowers patients. So some really hard-hitting quotes there from the patients. We wanted to focus in round two, and we got most of the information. It just needed further consensus in round three, but we're discussing about exercise type, exercise frequency, topics, delivery method. So, for example, the education topics, how long do they want the talk to last for? In what format do you want the talk to be presented? And we went all through that to find. And then finally, in round three, we were able to confirm the activities, the frequency, the location of the exercise, and how we monitor it. And then the education topics, delivery methods, and scheduling around the program. And this is the rehab program. Okay, so I'm going to go through it, so bear with me. So we've got the exercise on the left, and Joe put this infographic together, which is great. So walking, so in terms of exercise, what came through is that we had walking, strength training, balance training, aerobic training, and breathing and relaxation as the main things that people wanted to include in their rehab program. So as you can imagine, walking 4 to 6 times a week was the frequency, just getting, as Kim said, getting out there. You don't need any specialized equipment, maybe an umbrella at times if you're in the UK, but you can just go out for a walk and walk to, maybe if you're still getting a little bit of leg pain, walk to a level that's suitable for you and come back. Strength training is really, really important because with CLTI, movement has been restricted due to resting leg pain. So what happens then is if we don't use our muscles, we lose our muscles and we get muscle wastage. So all of a sudden that person becomes weaker and weaker and weaker, and activities of daily living become harder and harder and harder. So the patients told us that they would like this 1 to 3 times a week. Balance training is also 1 to 3 times a week, and balance training is really, really important, especially the older we get. We want to improve reduce fall prevention as well, so that's important. Aerobic training 1 to 3 times a week. So aerobic and walking might be slightly different because we could be walking and our breathing doesn't change, but with aerobic we're getting up to a certain intensity that challenges our breathing. And that's one of the major things that limits claudicants, is that they can't get to an aerobic level because their leg pain restricts them. So they have to do non-weight bearing exercise. And then a huge part of it was breathing and relaxation daily. These patients wanted breathing and relaxation daily. So the exercise component was agreed to be 1 day a week in a centre, in a supervised exercise environment with vascular specialists, and then the rest would be at home. Okay, so the strength, balance, aerobic would be 1 session a week in a rehab centre, then at home, and we're going to provide them with resistance bands and an activity watch and all these tools to enable them to enable that behavior change. And then the walking and relaxation they just wanted to do on their own at home, achieving that frequency, that desired frequency. We then, on the right hand side, we have the education, and these are the topics that we've not doctored the topics. These are exactly what came out in the research. The physical activity and exercise, topics that the condition and what causes it, so maybe a bit more knowledge there. Other medical conditions and risk factors. What happens if nothing is done? So what happens if you don't do any exercise, or you decline surgery? These are the things that came up. a bit more information on the types of surgery, because we all know that vascular surgeons are very, very busy people. And I've heard, I think Joe shared me a horror story really of a vascular surgeon at a hospital, and he was just basically doing his ward round, and he'd go to a patient, and you need an amputation, we'll get it sorted, and then just walked off to the next person, and that person was in tears thinking, oh my goodness, I needed amputation. So that more information on what's to be expected immediately after surgery, and then the types of surgery is really, really important. And then some information on medications.
It's interesting that this came for a post procedure. This is still post procedure. So some of those educational items, they can still be beneficial post, but it seems that they're like types of surgery, the medications involved, the condition itself should be in a pre-program.
Ideally.
But I guess if they're not, which it sounds like often that's the case, people have these procedures and they have no idea. I've had people come in and say that, yeah, I was told I have problems with my veins, and so they had to do a bypass, and they have no idea it's peripheral artery disease. It's not veins, and we still have to go back to the beginning. So there's always benefit to that, unfortunately, even post procedure. So I just had to point that out because that's definitely a gap in early care for these patients.
It's something that we're going to explore. Actually, we're going to do some interviews with patients while they're sitting there waiting for their surgery, to get their perspectives, because I completely agree. Do they get the correct information, or the amount of information that they want at that time, or is it just brief descriptions of what's happening, and then they find themselves on the surgical table, and that's it, done. So we want to explore, but I think also as well is there might be a barrier there to clinicians, because if you have some junior clinicians, they might not feel confident or have the knowledge about that disease to give the correct information. So it's something that, excuse me, that's going to be an adjunct to this project. So just wait for that coming. Hopefully soon, we're going to be looking at that. But what was really interesting is the education is that they're going to have a 20-minute presentation at the end of their exercise session, but they also wanted it in leaflet format to take home that they could read, so a slightly shorter version. And we've actually recorded on our private YouTube channel the talks where Joe is delivering the talk recorded, and therefore patients can look at it at their own time if they wanted to. So it gives the patient 3 different options how to get their education in, which is really, really important. I know Kim's forward this on, but this is actually the publication of it. So again, those are the authors. We have got a further paper under review at the moment that actually is about embedding patients into research and how patients contribute to this research. So I'll forward that on to Kim once it's released. But yeah, research is nothing without patient input.
Right. Yeah.
So the key points was that we've able from nothing to be able to have a rehab program that's ready for testing. This will be the first rehab program specifically designed for CLTI patients in existence. We have touched on addressing some priority setting research goals that were published in 2022 by Sean Pimer's group, and that set research priorities for peripheral artery disease, and we've addressed the #1 priority. And we're going to start recruiting the multi-center feasibility trial next month, which then hopefully I might get an invite back and I can go through the results of that feasibility. really important. And this is just the research team. I've tried to put soft focus on all the images, but I've not been able to do it too much. Okay. Thank you very much. I'll just stop
I think
sharing.
that's absolutely wonderful. And when do you expect, I might have missed it, when do you expect, when are you going to be recruiting, or what is the recruitment going to look like for this
Yeah,
program? And is it just going to be in Manchester, at least initially?
so it's two centres, one a hospital and one a community venue. So it gives us
Okay.
a bit of flavour of both, because in the UK, the NHS is really pushing towards more community-based prevention
Yeah.
and programs rather than the NHS. And it's going to be in Manchester and another city called Preston, which is about 30 miles away from Preston. So we've got two cities, community and hospital, and we hope recruitment might last about 10 months. So by the end of the year, I'm hoping we're done.
You're at least done with the recruitment,
Yeah.
or the whole study. You're hoping that you can get people. Do you know how long it's going to be, like a 12-week program?
It's a
Or is
12
that
week, yeah,
something?
sorry. Yeah,
It
it's a
is going to
12
be a
week,
12
it's a
week.
12-week program that kind of matches the NICE guidance in the UK. So that was sort of the foundation of it. And the study needs to finish everything all done by April next year, because that's when the NIHR deadline is. So we hope to be ready for publication by then and
So
developing the randomized control trial.
what will the parameters be for it? Are you going to, because if you end up with CLTI patients that have wounds, there's obviously, they're not going to be able to do the additional, that's a whole other bowl full of cherries, right? Because
Yeah.
they can't get out and walk. You're going to have to deal with offloaders and things like that. So I imagine these are people that have taken care of their feet and they have rest pain that wakes them up at night, and they
Yeah.
had a procedure.
Yeah. So the hospital site, which is an experience of dealing with and exercising transplants, whether it's the foot, we are taking amputees. They're not transplants. I've just been talking about heart transplant about an hour ago. Sorry, amputations. So we are taking amputations because the most important thing is this is a real world study, and 20% of the 20% of this group will have some form of amputation. So we are looking at, if the wound is relatively healed and we get clinical sign off, then we will be taking them. If it's an open wound, say at the foot, and the clinician reviews that, they will likely say no, they can't take part. But as part of the condition of the grant, because the NIHR picked up on it, is that we have to include amputees in this research, and they've been involved in the co-design as a co-applicant of W amputees.
Okay, but you have a graduated, like a gradual exercise program to walking. Do you have it for some of these patients? They might not be able to walk as rigorously as some of the other patients that don't have wounds, and maybe you start them off with some foot exercises, some cycling. Do you have that kind of thing integrated into it, or are these patients that have to be able to um, have what's the phrase I'm looking for? The Be able to stand on their own 2 feet and be able to put some pressure on it, at least
Yeah.
somewhat.
Yeah. So
Okay.
the rehab program is completely individualized to the person. We have access to bikes, we have access to other bits of recumbent bikes, arm ergometers for the arms and things. So we have equipment to manage that, but it will be individualized. So yes, they have to have some form of ambulation to be able to, but I'm not going to say, for example, tell someone you have to walk this far at this pace. It will just be individualized to them of how they can do. Like I said, the primary outcome of this is whether we can recruit and whether people adhere to the intervention, and then we sort of refine it if needs be before we go to a definitive randomized trial.
Okay. And for 3 in 5 people who suffer a heart attack have PAD, and a lot of these patients are not walking at a pace, and especially for a long period of time, that would give them any sort of cardio workout, are they going to, all the patients that are involved, are you going to do a full cardiac assessment prior to participation to ensure that their heart can keep pace with their feet?
Yeah, so every patient that recruited will undergo a clinical assessment before they start. They will do a walking test before they start, and like you said, it's very common in especially claudicants, when you make the exercise non-weight bearing, all of a sudden they get an aerobic stimulus, and then all of a sudden they get a bit of angina, because
Yep,
the plaque buildup is not just in the legs, it's everywhere. So
that's what
we
I
will
worry
be,
about.
yeah, we will be monitoring that closely. We do have strict exclusion criteria. And obviously with exercising, I'm from a cardiac rehab program. If someone develops angina and it's new, which is we would have to stop exercise, and we would then make the necessary referral to the cardiologist. If it is known and it's stable, again, which is important for exercise, if they do get angina and they've got a GTN spray, they can just use the spray. If it goes and the blood pressure is stable, we can get them back up and exercising straight away.
Yeah, I think this will also be a good test to even prove, how many patients um, truly do need to have a full cardiac assessment, prior to any of these programs. If you have PAD, the likelihood that you have CAD, fairly likely. So that might be something that is not an intended outcome or intended number, but that might help so many people across the globe, where surgeons say, well, until you actually experience the angina, we're not going to give you any testing. And these patients, they just can't get up to a pace to even give their heart a chance to trigger a symptom until
Yeah,
they actually have the surgery. I mean, I've had several patients, just two drop dead in a parking lot. Another one, literally the moment she rang the bell, by that Friday, she ended up having a heart attack and died. And, after 2 years of healing the wound and having these procedures on her legs, and she was so excited that she finally could get up and walk. And she went out for her first walk and she died. And I just think that we can't wait, that each one of these patients with PAD, especially if they have CLTI, they should have their heart a full assessment before they start a walking program. So I'm glad you're doing a full clinical assessment, and that they're going to be monitored with their progress afterwards. So maybe they don't have an issue that arises right away or rears its ugly head right away, but you're monitoring them as they pick up the pace, and
yeah,
you're doing it at a safe pace to make sure that if something is triggered, you can get them the care they need quickly. So I think that's great, versus discharging them, sending them home, and sending them on a walk,
yeah,
and
yeah.
they don't know
So
they're a ticking time bomb.
yeah, definitely, close monitoring is with these patients. Because again, it's going to be interesting. Obviously, with the research, we report any adverse events as research policy and things like that. So it will be, you can only do as much as you can with the UK. We can't request echoes just like that. We can't request an angio. There's only so much we
Nope.
can do to mitigate risk. So we can exercise test them beforehand to see if anything provokes. We can make sure that we meet all the exercise. We don't meet any of the exercise contraindications to exercise that would stop us.
Yeah.
So any new arrhythmia, anything like that. So, and they would be closely monitored. And one of the things that we will be speaking to them is about symptoms and things, and whether they were in the legs or whether they were in the chest.
Oh, I think this is going to do so much good for so many people, because that's the number one complaint that we have from people is, okay, I'm discharged. Like,
Yeah.
I don't understand. And we have even Mike here, and his mom had an amputation, and she still has another leg that should be checked frequently, but she was discharged. Like, are you kidding?
Yeah.
Wait a minute. Um, so it's nice to have this type of program available post procedure, and even for amputees. Well, maybe especially for amputees.
Right.
And so when are we going to get started? We're happy to help you promote the study and get it out there and help with the recruitment. I think that that's really exciting. I think that your results are going to have a global impact.
We hope so. We hope so. So it will be that will be the thing in developing the impact and moving it forward and engaging with societies, organizations and things. But we just need to get the evidence first. And
One step at a time.
Yeah, interview some patients after it to see how they find it. Did they like it? Why did patients drop out? Why didn't they enroll in the first place? Once we get that understanding as well to couple together with the results, then we will definitely be marching on to a national trial that will give us the definitive answer. You know, does it improve people's quality of life, and does it stop people going back into hospital at 1 year?
That's gonna be huge, I think. Does anyone have any questions about this? Maybe Kathy or Carolyn or Fiona? Anyone? I'm excited to get started on this with you guys and would love to hear every step of the way, what you have planned and what you're learning, because I just think this is going to be amazing. One of the questions, though, that a lot of our patients are always asking is, in terms of, just exercises to improve circulation aside from walking while they're sitting, are you going to include some of those exercises? I know there is in your supervised exercise therapy program, they talk about some isolated exercise, like up on your tippy toes and down on your heels and things like that. Is that going to be integrated into this program as well, so that when they're at home and they're sitting and they're eating dinner or watching TV, they can still exercise their toes, exercise their feet, get those calf muscles, their second heart pumping?
Yeah, absolutely. So obviously with peripheral artery disease and claudication, walking has always been the mainstay, and a lot of the research has been on the mainstay. Now, absolutely, we also need to improve the quality of the muscle as well, because without muscle we can't walk. Without muscle we can't do anything, and that slowly goes as I mentioned before. So yes, they will be calf raises, generally, basic, easy exercises that you don't need any equipment for, that you can easily do at home. And then, with resistance bands, doing some resistance exercises, some chair stands, those simple exercises to be incorporated in daily life is going to be really important.
Yeah. And how many days a week during this study? Because I noticed that you said like 4 to 6 days of walking and then 1 to 3
Yeah.
of
Yeah.
what do you call it? The strength training
The strength training.
exercises.
Yeah. So that the frequency that the patient chose is aspirational to try and build up to that. Absolutely. Like I've said, if someone just wants to do their one supervised session a week, we then try and build them up from there gradually. It's not going to be, we get a patient, right, you're walking 6 days a week, you're doing some strength twice a week, you're doing some aerobic, that's not the purpose. We've got the framework, we've got a guided frequency of what people told us they wanted, and then it will be building up gradually. Like any kind of rehab program, you start low and then you gradually build it up to what the patient wants to do, but also can continue doing long term. It becomes part of their day. So we will see how that goes, because again, this is into the unknown. This is exploratory. We have got nothing to go off really in CLTI, so it would be interesting where it takes us. But patients will be recording their activity as well at home.
And this is where I really like your idea of the community-based program, because it would be just like you go to the gym every single day. Is that kind of the theory behind it, that you want them to get used to going to the gym and starting to integrate a variety of different exercises, whether it's walking, strength training, whatever it is, on a daily basis almost? I mean, for me, I it's part of my job. I mean, I will, exercise 5 to 6 days a week. It's just part of my daily routine. But for so many of these patients, it's not, because especially with having a wound and,
Yeah.
the pain for so
There's a
long,
big
they just
social
can't.
side of it as well, isn't there? Sort of, we find where
Yeah.
I'm based in the rehab centre, we get people who are that isolated. The only time they ever speak to people is when they come to exercise. And that social side and that mental health side can be just as important as the physical as
Yeah.
well. So yeah, it's really important that we've got that community exercise facility, as well as being able to do something at home. It's got to be a holistic approach, hasn't it?
Yeah. And I just wonder, the transitional aspect of it. And that'll probably be a secondary say, let's just prove that this works. And then how do you, it's great if you get people to stick with it, but then how do you get the reduce the, in a sense, recidivism rate, beyond the time that they have with you? How do you end up getting them to stick with it going forward?
And
Because
again,
I
this
know,
is, sorry, I was going to say, the whole point of this feasibility trial is to understand this. Will do they uptake in the first place? If not, why? What are those barriers? If they do uptake, do they drop off? If they drop off, why are they dropping off? How can we support that? If they do adhere to the whole 12-week program, and why? What did they like about it? What enabled them to do that? And then can they move forward? Can they then do something themselves after those 12 weeks? If they can, why? What have we achieved? So once we've understood that, and we understand the feasibility of it, we can then sort of address any barriers, we can refine the program, then we can take it to that sort of national trial. So this feasibility bit is going to be really interesting to sort of understand.
and I don't want to put you on the spot here, but this question came to mind. Here in the United States, some research that I had done on PAD programs, preventative programs, their supervised exercise therapy programs to prevent a procedure in the first place, just for mainly intermittent claudicants, early lifestyle limiting claudication patients. But in a study, they had a more 70 to 75% retention rate for the 36 sessions. But when you look at the regular Medicare enrollment, just in general for these supervised exercise therapy programs, only 5% actually complete the 36 sessions. And here they attributed to, three things. One, it's too time intensive. Two, finances, because here many of these patients have to pay a copay. But the third is transportation or lack thereof. So I'm curious about those, at least two of the three factors for the NHS, and if that you're concerned about that at all.
I think with any rehabilitation program, cardiac, pulmonary, stroke, the barriers seem to be, there's a lot of similarities between cost, travel. Our old claudicant class, I think patients had to walk maybe 5-7 minutes just to get to the physio gym, and had to stop a couple of times. So yes, we have considered this with the trial. We are paying travel expenses for participants just to try and get them through the door at the moment. But this is something that we need to absolutely think about, and that's why we've got like a kind of home-based element as well in the rehab program, where they can do strength, aerobic, balance, relaxation at home, and might just need that soft touch from a centre rather than having to be there 2-3 times a week. They can just have maybe a weekly phone call, follow up to see how they're getting on, motivate them, and then do it at home. So patient preference, it all comes down to, some people want just face to face, some people want a bit of a hybrid, and some people want it all at home. It's giving them the choice basically of what they want to do. But 5% is quite a low number of completions.
I know that was, it was even lower than the cardiac rehab. They say that, 40 to 50% of people here end up dropping out halfway through. And then when they followed up a year later with these patients who did complete it, it was literally like this much that maintained what they had learned in the program that they had done a year later, which is really sad. So I love the integration to, with home-based exercises and such that will help them to integrate it into their life. It's one thing to go there and to use the treadmills and to use the equipment there, but is that going to be something that they can continue and integrate into their everyday routines? So I'm really excited to see what you guys come up with, and I'm hoping for some incredible results that are going to have the global impact. So
No pressure. No pressure.
no pressure.
Yeah.
But we're here. Whatever we can do to support you,
Amazing.
I can add
Thank
you
you.
into we have our UK support group as well. We're happy to integrate you into the group in case you guys have follow-up questions or want to start chats, anything that can help you out in there. We're also happy to include you on our PADtrials.org and do more videos like this to help get the word out there and help with whatever recruitment. Because I think it'd be fun to get, our members involved and help you out.
Great. No, that sounds perfect.
And
Awesome.
thank you
Well,
to all of the people who did take part from this site. There were, I know there were quite a few from here, so we really do appreciate it. Thank you.
Oh, and Kathy has before we head out. Kathy, go ahead.
A quick question just on that topic, Joanne. How did you explain how you spoke to the patients that you didn't meet in clinic? How has that been noted in the research, that where you got these patients, like people like us, where you got us from?
So it's if you have a look in the write-up, and there's a section on the recruitment and where we recruited from.
And what does it say?
Oh, for where we recruited from?
Yeah.
Let's have a look. Just got it here.
Just, it's not unrelated to what Kim said about reaching people via distance and connecting people remotely, because we're all here because we're connected remotely by this group.
Yes.
But we just don't seem to exist, being recognised as by the NHS at all. And the power of, when we have walking challenges, people participate, people report, and we have a much better stick rate than 5%.
We do.
But we don't seem to figure in any real. You could really use a group like this.
Absolutely. No, you
but we're
right
not really. We're just not really recognised. Because of the difficulty of it being a Facebook group, basically.
Yes.
So I just wondered how you actually said where you got the patients from.
Yeah, so in the recruitment, we've said how we've kind of used predominantly sort of the social media platforms, such as the Facebook groups.
It would be great if you could.
That's good.
Yeah,
but it would be great if you could be specific, with which groups and versus just general social media, because I think it's it kind of hurts the credibility of, I think, the social media groups, because there are ones that are not run properly and are not facilitated. And like, for example, ours actually has high-level people through the NHS, including Dr. Christine and including Dr. Saratzis is in there, and we have several other vascular surgeons that make sure that we don't deviate.
Yes, yeah, definitely.
The thing is, it's not about the risk of the research or the credibility of that. These are just real people living real lives.
Yeah.
And we have our own level of risk that we face every day. The notion of, taking your blood pressure when you've got to put the bin out kind of thing is kind of ridiculous. This is people's real lives, whether you take their blood pressure before you say they can walk, they still have to go and put the bin out. They still have to go and get a bus. They still have to go to the shops. So, there's no risk by citing an online support group, as long as you say we are not affiliated. you know, and then people can make their own decisions about whether or not they trust that group. You don't have to take the responsibility for them.
No, we've definitely sort of mentioned how with most of our sort of recruitment came through the social media groups, and then we've acknowledged you, you know, down in our acknowledgements as well, because you're right, it's really important we do reach people and know people like you and groups that, you know, do exist. So you're definitely a vital part of it, and we've certainly acknowledged you because we do appreciate it.
No,
Yeah,
that's good.
well, it'd be great if you could even, you could name.
Yeah, we have. We honestly, I'm just reading. If you look
Did
at
you
those
really?
acknowledgements, and we've mentioned the Global P.A.D Association, you are there, honestly. And we did mention that Thanos as well, because he came and did a webinar to start with, didn't he? So we mentioned how, so in the recruitment, it even says how he came on to do a webinar with yourselves, you know, and that generated some recruitment for us as well. So yeah, no, we definitely will shout about you as much as we can.
Yeah, and hopefully we'll have more with both of you going forward, because we'd love to keep the conversation going, and especially if you can, you know, even answer additional questions just to keep, you know, present on the different aspects of, you know, if you have certain exercises that you're trying out or whatever, just come and join us. And we're here every single Wednesday. We have both the 4 o'clock group, which is our walking and exercise seminar group, where, you know, we come, we learn. For example, today we even had a retired exercise physiologist who, you know, started exercise therapy programs for CAD and P.A.D and used the same theories to work with NASCAR, with racing teams, and ended up bringing down with his training programs the pit stop time from 16 seconds to 12 seconds. And he's world renowned for his efforts. So he came in today and he was answering questions. And we like to have different people every week with different topics. And, you know, it will help. We'll continue with every single one that you participate in. We'll put a little plug in there. Hey, if you're in this area, make sure to join and learn about this research study, you know, clear through the end of the year.
Amazing.
So thank you so much. We look forward to partnering with you in the future. Is there a website or anything if people want to learn more, at least in the meantime? I do have the link to your publication actually in the description, but
yeah, anyone can email me anytime. You've got my email, Kim. So we will be setting up a website once we go through to the full randomized control trial. So we will be doing that, and we'll be able to put that out there, hopefully, if we're successful. But yeah, anyone can email me. You know, that's absolutely fine if anyone's got any questions or anything.
And if anyone in the meantime, you're watching this video, go to padtrials.org, and we're going to make sure to get the trial actually on the website as soon as it becomes available. But also we do have a patient registry. And if you do say that you're in the area where this particular trial is going to take place, we'll make sure to message you and let you know when it opens up, so that we can pass along your information to them and get you hopefully qualified and registered to help influence the future of P.A.D care post-procedure. But thanks everyone for joining us. Don't forget, like the video, subscribe to our channel, and have a great week.
Thank you.